Scallop and fenestration modification of Cook Zenith Flex endovascular graft for treatment of juxtarenal abdominal aortic aneurysm. This is a case of a patient with juxtarenal aneurysm who was not a candidate for open repair due to his comorbidities and age. We utilize Zenith Flex bifurcated device for back table modification. We first marked the orientation at 6 o'clock and 12 o'clock position. Prior to surgery, we 3D reconstruction as well as Terra Recon imaging system to plan our case. Fenestrations and scallops are created using handheld cautery, and then we reinforced both fenestration and the scallop with the nitinol and gold gooseneck snare. The scallop is created in a triangular shape as the proximal portion of the graft is constrained, and it will widen out to a more U shape once the proximal suprarenal stents are released. Here you can see that we are reinforcing each fenestration with same nitinol gold gooseneck snare in running circumferential fashion. Corner of the each four corners of the fenestrations are then secured with additional figure of 8 sutures. Similarly here, the left renal fenestrations are created. Again, we use fibropearline sutures in running circumferential fashion. Each stitch is locked. This is a key step where the contralateral leg is secured with a pearline suture. Without this, the contragate can kick out instead of staying down and make the cannulation much more difficult. Next, the graft is constrained circumferentially using a 3/0 chromic sutures. This will be broken in the OR with a balloon after the cannulations have been completed. We often use aortic sizers to size our constraint to a desired diameter to make the cannulations easier. When we perform this part of the step, we use the back end of the needle to run it between the stent and the fabric to make sure we don't create any additional holes in the endograft. With the help of the assistant, we constrain the device and we tie down our chromic sutures to achieve a desired constrainment to help facilitate the maneuverability of the graft and the cannulation. Next, the device is reloaded back into the peel away using a help of umbilical tape to squeeze out the graft. We do this sequentially, and once the device is all loaded back into the peel away, afterwards it can be easily advanced back to its original configuration. You can see the graft being deployed here. We use the intravascular ultrasound to mark the location of our target vessels. Each vessels are then cannulated, and we like to leave a sheath and a stent in place for one of the renal fenestrations to ensure that there is no migration of the device. Then we use the balloon to achieve a proximal and distal seal, as well as at this time we use the balloon to break the chromic sutures. The target vessels are then stented. Bilateral common iliac limbs are deployed. And this is the final angiogram. And then the completion CT scan. There's no evidence of endoleak and preservation of target vessels with only 2 visceral artery stenting. And this is the 3D reconstruction of our repair.